Hi, everyone. This is the Heart Rhythm O2 podcast. I'm Jeanne E. Poole, the editor-in-chief. I will be reviewing the abstracts of the great papers that we have in this issue and highlighting the key findings. The first paper is titled Long-Term Outcomes of Triple Site versus Dual Site Cardiac Resynchronization Therapy Using Temporary Pacing to Guide Individualized Implantation by Dr. Michio Ogano and colleagues. The background is that CRT is an effective treatment for chronic heart failure, but dual-site pacing may not fully eliminate electrical dyssynchrony. Triple-site pacing, adding an additional left ventricular pacing site, may enhance CRT outcomes. The objective of the author's study was to examine the long-term effects of dual versus triple-site CRT. The authors looked at 92 patients with New York Heart Association Class 2 to 4 heart failure between 2010 and 2016. All patients had to have standard indications for a device. Patients underwent invasive pacing studies, had usual measurements made, and then based on the QRS narrowing and the DP-DT max improvements, patients were assigned to triple or dual group. The clinical outcomes, including the clinical composite score, New York Heart Association class, QRS duration, heart failure events, and mortality, were followed over an average of 8.3 years. For the results, the authors note that at 1 year, the triple site pacing group had significantly better CCS outcomes compared to the dual pacing site group with a p-value of 0.018. Long-term follow-up also showed a significantly lower heart failure event rate in the triple pacing site group. A multivariate analysis was conducted, and that identified triple site pacing as an independent predictor of reduced heart failure events with a p-value of 0.018. Despite a shorter battery life in the triple site pacing group, device replacement rates were similar. The authors conclude that temporary pacing-guided triple-site pacing CRT provides significant long-term benefits over dual-site pacing CRT by reducing heart failure events. The authors posit that these findings support the necessity of individualized assessment and approaches to eliminate electrical dyssynchrony when considering multi-site pacing CRT. The next paper also focuses on cardiac resynchronization therapy and is titled Agreement on Site of Latest Electrical Activation Between the Right Ventricular Pacing and Intrinsic Conduction as Target for Left Ventricular Lead Position in Cardiac Resynchronization Therapy by Dr. Henrique Laritz-Pierre and colleagues. The background for this paper is that CRT studies indicate that targeting of the left ventricular lead toward the site of latest electrical activation could improve clinical outcomes. Whether this site should be determined during RB pacing or intrinsic conduction is not known. The objective of this study was to investigate agreement between RB pacing and intrinsic conduction in identifying the site of latest electrical activation in patients undergoing CRT. The methods of this study are that during CRT implantation, the authors obtained pairwise measurements of the interval between QRS onset to local LV activation during intrinsic conduction, or QLV, and the interval from the paced signal on the RV lead electrogram to the sensed local LV activation during RV pacing, RV pace to LV sense, in the basal, mid, and apical positions of eligible veins in patients randomized to the intervention arm in the Danish CRT trial. Venous anatomy and final lead positions were verified by computed tomography. The results are that a total of 61 patients were included in this study and measured intervals in 209 veins with 531 segments. The authors found substantial agreement between RV pace to LV sense and QLV in identifying the latest activated vein. The RV lead was predominantly positioned toward the anteroseptal region, and RV pace to LV sense favored a posterior vein more often than QLV. The authors found high intra- and inter-observable reliability for RV pace to LV sense and QLV measurements. The authors conclude that there is substantial agreement between RV pace to LV sense during RV pacing and QLV during intrinsic conduction in identifying the optimal target for LV lead position during CRT. The authors state that the optimal target vein changed for 1/3 of patients as RV pace to LV sense favored a posterior target more often than QLV. The focus of the next paper is left bundle branch area pacing. The title of this paper is Evaluating Electrical Stability in Left Bundle Branch Area Pacing for Bradycardia Patients at Follow-Up by Sam Briongos Figueroa and colleagues. The background of this is that physiologic pacing is safe and feasible, but whether electrical synchrony persists at follow-up in patients undergoing LBBAP is unknown. The objective of this study is to determine performance of electrical synchrony in left bundle branch area pacing patients at follow-up. The methods are that consecutive patients with successful LBBAP for bradycardia pacing indication and preserved left ventricular ejection fraction were selected. At follow-up, a 12-lead electrocardiogram was recorded, along with echocardiography for myocardial work analysis. V6 to R wave peak time, V1 to R wave TP, and QRS duration were compared. 149 patients were studied. After 18.2 months, V6 to RWTP decreased from 74.4 plus or minus 8.9 milliseconds to 71.5 plus or minus 10.6 milliseconds, which was statistically significant in left bundle branch pacing captures, and from 90.9 plus or minus 7.2 to 85.7 plus or minus 9.3 milliseconds, which was significant also in left ventricular septal pacing captures. Further, V1 RWPD decreased from 120.5 to 111 milliseconds at follow-up, p less than 0.001, in LBB pacing, and from 118 to 9.9 milliseconds in LVS pacing. Paced QRS duration was also significantly reduced in left bundle branch pacing, and at follow-up, 29 patients lost the right bundle branch delay pattern in V1, but QRS duration remained unchanged at implant. Mechanical synchrony in patients with and without right bundle branch delay pattern were similar. The authors conclude that in patients undergoing left bundle branch area pacing for bradycardia pacing, electrical synchrony remains stable over time, suggesting that left bundle branch area pacing is a reliable and durable method for physiologic pacing. The next paper is titled Vein of Marshall Ethanol Infusion Improves Ablation Outcomes in Patients with Persistent Atrial Fibrillation by Dr. Mohammed Al-Sadawi and colleagues. For background, the vein of Marshall ethanol infusion may improve outcomes amongst patients with persistent atrial fibrillation undergoing catheter ablation procedures. Prior investigations used heterogeneous ablation strategies, limiting the understanding of vein of Marshall ethanol infusion. The objective is the study sought to examine the safety and efficacy of a uniform ablation approach using vein of Marshall infusing compared with patients undergoing pulmonary vein isolations only, or PVI and posterior wall isolation. Patients undergoing first-time ablation for persistent AF using vein of Marshall infusion with PVI, PWI, and ablation of induced macro reentry arrhythmias were included. Two propensity-matched control groups, PVI only and PVI plus PWI, were identified with a 2-to-1 matching. Safety and efficacy rates between the groups were examined. A total of 155 patients were included with vein of Marshall, which was 31 patients, PVI, 62 patients, and PVI plus posterior wall of 62 patients, consisting of a total of 98 patients, of whom 63% were males, and the median age was 66 years, and left atrial diameter was 49 millimeters. The ejection fraction was 50% plus or minus 16%, and the follow-up time was 3.2 plus or minus 2.2 years. There were no significant demographic difference between the two groups. The 1-year rate of freedom from atrial arrhythmias after a single procedure was 84%, 67%, and 54% for patients undergoing vein of Marshall infusion, PVI only, and PVI plus posterior wall ablation, respectively. Log-rank p-value of 0.021. Patients who underwent vein of Marshall had improved outcomes compared with patients who did not, hazard ratio 0.32, p-value of 0.01. With fewer repeat procedures, 10% versus 37%. Procedure, radiofrequency, and fluoroscopy times were greater in the vein of Marshall ethanol infusion groups. The authors conclude that amongst patients with persistent atrial fibrillation, an ablation strategy incorporating vein and Marshall ethanol infusion improves the long-term ablation outcomes compared with groups of propensity-matched patients undergoing PVI only or PVI plus posterior wall ablation. Next up is a paper titled Reduced Continuity Index with Proactive Esophageal Cooling Compared to Luminal Temperature Monitoring During Radiofrequency Ablation by Catherine Lazarus and colleagues. Background for this paper is that proactive esophageal cooling is FDA cleared to reduce the likelihood of esophageal injury during radiofrequency ablation for treatment of atrial fibrillation. Long-term follow-up data have also shown improved freedom from arrhythmia with proactive esophageal cooling compared with luminal esophageal temperature monitoring during pulmonary vein isolation. One hypothesized mechanism is improved lesion contiguity as measured by the continuity index with the use of cooling. These authors aimed to compare the continuity index of PVI cases using proactive esophageal cooling with those using luminal esophageal temperature monitoring, or LET. The authors calculated the continuity index for PVI cases at two different hospitals within the same health system using a slightly modified continuity index to facilitate retrospective determination from review of recorded cases. The results were then compared between cases using proactive esophageal cooling and those using luminal esophageal temperature monitoring. The authors found that the continuity indices for a total of 236 cases were determined, 118 cases using proactive esophageal cooling and 118 cases using traditional LET, or luminal esophageal temperature monitoring. With proactive esophageal cooling, the average continuity index was 10.6, which was 5.6 on the left pulmonary vein and 4.9 on the right pulmonary vein. With LET monitoring, the average continuity index was 37 on the left and 18.3 on the right, for a difference of 26.4, which was significant. The authors conclude that proactive esophageal cooling during PVI is associated with significantly improved lesion contiguity when compared with LET monitoring. This finding may offer a mechanism for the greater freedom from arrhythmia seen with proactive cooling in long-term follow-up. The title of the next paper is Conduction Characteristics in the Left Atrium of Patients with Perimitral Atrial Tachycardia, Post-Pulmonary Vein Isolation by Dr. Mitsuru Takami and colleagues. The background of this paper is that the electrical conduction properties of the left atrium in patients with perimitral atrial tachycardia after pulmonary vein isolation are not completely understood. The objectives of the study was that the authors were to investigate the characteristics of the segmental conduction velocity in the left atrium using multi-site pacing in patients with perimitral atrial tachycardias. After PVI in 179 patients, left atrial anterograde and retrograde propagation maps were created via pacing at different sites. Segmental CVs were measured in 7 distinct segments of the LA in both maps. Burst pacing was performed to induce atrial tachyarrhythmias. 12 PMAPs, 7 clockwise rotation, 5 counterclockwise rotation, were induced in 11 patients, the PMAP group, whereas no atrial tachyarrhythmias were induced in 56, which was the no induction group. Comparing the segmental conduction velocities between the PMAP and no induction groups, the authors observed significant reductions in the PMAP group conduction velocities, not only in the anterior and septal regions, but also in the roof and bottom regions. Direction-dependent conduction delays were also observed in regions without or with small low-voltage areas, especially in the left atrial septum, lateral, and bottom. In the PMAP group, the very slow conduction area during PMAP consistently matched the reason of the most reduced conduction velocities during either anterograde or retrograde propagation. Additionally, the direction of greater conduction delays in the anterior left atrium identified during pacing studies matched the direction of the PMAP rotation in 9 of 11 patients. The authors conclude that patients with perimitral atrial tachycardia showed distinct segmental conduction velocities in the left atrium, which may influence the tachycardia circuit formation and rotational direction. Next up is a paper titled Glutathione Peroxidase 4 as a Potential Biomarker for Atrial Fibrosis and Recurrence of Atrial Fibrillation by Dr. Tong Liu and colleagues. The background of this study is that atrial fibrosis mediates the development and maintenance of atrial fibrillation. Glutathione peroxidase 4, or GPX4, is a ferroptosis biomarker. Little is known about ferroptosis in AF or the relationship between GPX4 and atrial fibrosis. The purpose of this study was to evaluate the predicted value of GPX4 for atrial fibrillation recurrence after ablation and the relationship between atrial fibrosis and ferroptosis. The study included 249 patients with atrial fibrillation who underwent ablation. The levels of serum GPX4 and transforming growth factor beta TGF-beta were evaluated by enzyme-linked immunosorbent assay. The primary outcome was AF recurrence during 12 months of follow-up. The authors found that according to the tertiles of TGF-beta, 249 patients were divided into 3 groups. With the increase of TGF-beta, the serum level of GPX4 was decreased. After 12 months of follow-up, 54 patients experienced recurrence of atrial fibrillation. Multivariate Cox regression analysis revealed that GPX4 level was an independent predictor of recurrence, the hazard ratio 0.308. After adjusting for potential confounding factors, the tertiles of GPX4 remain predictors of AF recurrence. Correlation analysis indicated that GPX4 was associated with atrial fibrosis and left atrial size. Receiver operating characteristic analysis showed that the cutoff value for AF recurrence was 3,740 picograms per milliliter. Furthermore, incorporating GPX4 into the left atrial dimension index and TGF-beta model significantly improved the prediction of recurrent AF risk. GPX4 showed excellent predictive value for AF recurrence and is negatively correlated with TGF-beta, indicating that ferroptosis may be involved in atrial fibrosis. This model can serve as a reference for clinical decision making. The title of the next paper is Clinical and Socioeconomic Factors Associated with Recurrent Atrial Fibrillation After Catheter Ablation or Antiarrhythmic Drug Therapy by Dr. Jeanne E and colleagues. The background of this paper is that maintaining sinus rhythm after initiating rhythm control strategies in AF remains challenging. The purpose of the study was to investigate risk factors associated with AF recurrence among patients with incident AF who underwent catheter ablation or received antiarrhythmic drugs. The authors identified adults with incident AF from 2010 to 2017 who underwent catheter ablation or initiated antiarrhythmic drug therapy from 2 U.S. healthcare systems and were followed through 2019. Using the electronic health records and a validated natural language processing algorithm, the authors evaluated the 12-month cumulative incidence of recurrent AF and examined the associations between clinical and socioeconomic factors and AF recurrence using fine-grained subdistribution hazard models. There were 982 patients who underwent catheter ablation and 18,025 who initiated antiarrhythmic drug therapy. The 12-month incidence of recurrent AF was 55.5% and 62.7% respectively, with median times to AF recurrence of 168 and 24 days respectively. Heart failure was associated with AF recurrence after catheter ablation, with an adjusted hazard ratio of 1.41, and antiarrhythmic drug therapy with an adjusted hazard ratio of 1.30. Low educational attainment and higher low-density lipoprotein cholesterol were associated with AF recurrence following catheter ablation. Obesity, hypertension, and lower estimated glomerular filtration rate were also associated with AF recurrence following antiarrhythmic drug initiation. The authors conclude that heart failure, dyslipidemia, obesity, hypertension, reduced estimated glomerular filtration rate, and living in neighborhoods with low educational attainment were associated with higher risk for AF recurrence, emphasizing the importance of identifying and managing modifiable risk factors in AF. The title of the next paper is Neighborhood Characteristics and Outcomes in Patients with Atrial Fibrillation, a large cohort study in the Midwest, by Peter Salama and colleagues. The background of this study is that the communities in which people live may affect their health. The purpose of the study was to investigate the relationship between neighborhood characteristics and outcomes in patients with atrial fibrillation. The authors looked at patients with new-onset AF identified from a 27-county region between 2013 and 2017. Addresses were linked to population density, Rural-urban commuting area, or RUCA, abbreviated, categorized as urban, large town, small town, and isolated rural, and neighborhood socioeconomic status, using the Area Deprivation Index, or ADI, categorized into quartiles of the national percentile rankings. Cox regression determined associations between RUCA and ADI with outcomes. Analyses were restricted to 90-day survivors. The authors found that among 13,233 patients with a mean age of 73.8 years, 57% men, 744 of that group had an ischemic stroke or transient ischemic attack, 3,077 developed heart failure, and 5,989 had died over a mean of 4.6 years. Persons living in isolated areas experienced a higher risk of death compared to urban areas, with a hazard ratio of 1.14. An increasing risk of death was observed with increasing ADI, and when stratified by age, no difference in survival was observed across RUCA or ADI categories for those aged equal to or greater than 85 years. In individuals aged less than 65 years, an increased risk of heart failure was observed with increasing ADI. There was no association between ischemic stroke, TIA, and RUCA categorization or ADI quartile. In conclusion, the authors state that patients with atrial fibrillation living in isolated areas and more socioeconomically disadvantaged regions experienced increased risk of death. Understanding this connection is vital for both current and future attempts to mitigate these disparities. The next paper is titled A Machine Learning-Based Risk Prediction Model for Atrial Fibrillation in Critically Ill Patients by Dr. Laith Alamari and colleagues. The background of this paper is that atrial fibrillation in critically ill patients increases morbidity, hospital stays, and costs. Existing prediction tools are limited in intensive care unit settings. The objective of this study was to develop a machine learning-based model to enable early AF risk identification and prevention. In this retrospective cohort study, adult patients were admitted to the ICU, were identified from the MIMIC IV, which stands for Medical Information Mart for Intensive Care, IV database. And the IV is the Latin number 9. This included 47 clinical and laboratory variables. The primary outcome was AF within the first 48 hours of admission. Multiple machine learning models were trained to predict AF, with the top performing model undergoing hyperparameter tuning. A compact model was developed using 15 variables and 2 novel features, one identifying patients 70 years of age or older with sepsis, and another representing a composite score of pre-existing cardiac risk factors. Model performance was evaluated using accuracy, area under the receiving operator, characteristic curve, and predictive values. The SHAP, which stands for Shapley Additive Explanations analysis, interpreted individual feature contributions to the model's prediction. The cohort studied comprised 46,266 ICU patients, with 4.6 of these developing AF within 48 hours. The CAT-BOOST classifier model achieved an AUROC of 0.850 on the test set, while the compact model with new features yielded an AUROC of 0.82. SHAP analysis highlighted total serum magnesium, age, and the newly created features as key predictors of AF development. This study demonstrates the potential of machine learning models in predicting AF development in ICU patients. The compact model with a satisfactory AUROC can be a valuable tool for identifying high-risk patients and facilitating timely interventions. Staying with the theme of atrial fibrillation, the title of the next paper is Association of Atrial Fibrillation Burden and Clinical Profile with Blood Biomarkers, Results from the Isolation Ablation Cohort by Dr. Zarina Habibi and colleagues. The background of this paper is that advances have been made in identifying biomarkers for atrial fibrillation outcomes. The objective of this study is stated as the link between clinical determinants, especially AF burden, and blood biomarkers remains underexplored. The authors conducted a cross-sectional analysis of AF patients scheduled for catheter ablation in the isolation study. Patient characteristics and blood samples were collected before ablation. AF burden was assessed using handheld electrocardiograms over 4 weeks. Blood samples were analyzed for biomarkers including bone, morphogenetic protein 10, angiopoietin, and fibroblast growth factor 23, and others. The authors trained elastic net regression models to identify the most important clinical determinants out of 64 available clinical features. The authors analyzed blood samples from 508 patients with a mean age of 63, 31% were female. Of these, 70% had paroxysmal AFib and 30% had persistent atrial fibrillation. Heart failure was present in 15%. In 28% of the patients, AF was observed during a blood draw. AF burden before ablation was available in 389 patients. After multivariable analysis, the following clinical determinants were independently associated with biomarker levels: AF burden, AF during blood draw, age, heart failure, decreased kidney function, and female sex. Most notably, AF burden and AF rhythm at the time of sampling were strongly associated with various biomarker levels. Female sex was positively associated with BMP10 and FGF23, but negatively associated with high-sensitive troponin T. The authors conclude that AF burden is a strong determinant of many biomarkers, underpinning their relevance as covariates in biomarker studies. Profibrotic biomarkers are increased in female patients, whereas male patients more often show elevated biomarkers of myocardial injury. The next paper is titled, "Is a single lethal electric field threshold sufficient to characterize the lesion size in computational modeling of cardiac pulsed field ablation?" by Dr. Argyrios Petros and colleagues. The background of this study is that pulsed field ablation is a novel cardiac ablation technology based on irreversible electroporation, abbreviated as IRE. PFA computational models rely on identification of a lethal electric field threshold to predict the IRE area. However, the predicted lesion anisotropy ratios, width over depth, vary extensively among recent studies, and these discrepancies remain a subject of discussion. The objective, as stated by the authors, is that this study aims to evaluate the predicted lesion anisotropy ratios using a PFA computational model by applying it to an open chest in vivo porcine model geometry. 6 domestic swine underwent epicardial PFA applications using a previously described waveform protocol. Animals were killed at least 3 hours after the last ablation, and lesions were assessed using triphenyltetrazolium chloride, or TTC, staining. Numeric simulations were performed on a segmented and meshed porcine thoracic computed tomography scan, mimicking the open chest experimental setup. The authors found that the maximum width of all simulated lesions was observed at the epicardial surface. The anisotropy ratios of the experimental lesions were smaller than the simulated ones. Increasing the peak voltage resulted in larger lesions. However, the computational model clearly underestimated the increase in lesion depth compared with the experimental data. The authors conclude that their computational model shows that a single lethal electric field threshold is insufficient to accurately predict both lesion depth and width in cardiac PFA. Their study suggests that for the given PFA waveforms, a threshold between 270 and 500 volts per centimeter provides satisfactory lesion depth estimations, and a higher threshold between 790 and 1,000 volts per centimeter better captures the lesion width. The title of the next paper is "Screening Cognitive Impairment in Patients with Atrial Fibrillation, a Deep Learning Model Based on Retinal Fundus Photographs" by Dr. Jeanne E and colleagues. The background of this study is that patients with atrial fibrillation have a higher risk of cognitive impairment. However, complexity of cognitive impairment diagnosis and lack of simple screening approaches limited early screening and intervention of cognitive impairment in AF patients. Their study aimed to develop deep learning models based on fundus photographs for easy screening of cognitive impairment in AF patients. Between May 2021 to April 2023, patients who completed fundus examination and cognitive function evaluation in the Chinese Atrial Fibrillation Registry study were included. The training and validation sets were randomly split at an 8:2 ratio. Participants from the Beijing Eye study served as the external validation set. Different deep learning models were trained, and their CI, or cognitive impairment detection ability, was validated. A total of 899 patients in the Chinese atrial fibrillation registry study were included. In the validation set, the vision ensemble model based on fundus images alone had an area under the receiver operating characteristic curve, or HRO2, of 0.855. That was for the CI screening. The multimodal model, based on fundus photographs and 4 clinical variables, performed comparably to the vision ensemble model with an HRO2 of 0.861. The HRO2 of the vision ensemble model for CI screening achieved 0.733 in the external test set. In the saliency map, the vision ensemble model focused on areas around retinal vessels and the optic disc. The authors concluded that a vision ensemble model based on fundus images might be practical for preliminary screening of cognitive impairment in atrial fibrillation patients. The next paper comes from our Global Voices section. The title is Validation of a Handheld Electrocardiogram 6-Lead Recorder to Obtain Chest Lead Equivalence, an African Heart Rhythm Association study by first author Dr. Thomas Slater and colleagues. The background of this study is that handheld electrocardiograms can be used easily in remote centers at low cost and are therefore attractive options for rural and low-income settings. A modification to the Cardia 6-lead ECG has been developed to record chest leads V2 and V4 by placing the device electrodes in standard V2 and V4 position. The purpose of the study was to validate this novel technique against the 12-lead ECG in a multi-center cohort from Africa and the United Kingdom to determine whether recordings are adequate for clinical use. Adults greater than 18 years of age who required an ECG as part of routine care were invited to participate. A 12-lead ECG was obtained, followed by a 6-lead ECG using the Cardia 6L. Then V2 and V4 chest lead equivalents were recorded. The primary endpoint was agreement between QT interval measurements in V2 and V4 on 12-lead ECG and Cardia 6L. Secondary endpoints assessed included rate, rhythm, PR interval, QRS duration, QRS amplitude, and ST segment abnormalities. A total of 1,786 recordings were collected from 11 sites. Hypertension was the primary indication for getting the ECG, or 28%. The coefficient of determination for QT interval in leads V2 and V4 was 0.59 and 0.61 respectively, within the pre-specified limit of agreement. The adjusted R2 for multiple ECG parameters was greater than 0.5, indicating satisfactory agreement. The authors conclude that modified chest lead recordings using the Cardia 6L handheld ECG recorder compared well with gold standard 12-lead ECG recordings and provide a basis for future simulated 12-lead ECG recordings using the Cardia 6L. They conclude that this could improve accessibility of high-quality ECG recording and interpretation in rural, low-income settings. Next up is a topics in review paper. The title is Uncovering the Mystery of the Atrial Ventricular Node Dual Pathway Electrophysiology by Xiangtou Ma and colleagues. The abstract states the following: with the discovery and validation of a novel index of dual pathway electrophysiology known as the His electrogram alternans, major advances have been made in understanding the electrical propagation through the atrial ventricular node. At slow rates, AV conduction starts at the interatrial septal boundary of the node, which is the superior nodal domain, and spreads toward the tricuspid annulus side, which is the inferior nodal domain, in a direction that's perpendicular to the AV axis and across fiber orientation. Such activation results in an early superior input into the superior His bundle. And this is the fast pathway conduction. At fast rates, the fast pathway wavefront gradually withdraws from the inferior nodal domain, permitting excitation formed at the crista terminalis end of the node to propagate longitudinally through the inferior nodal domain, also along the fiber orientation, to activate the inferior His bundle. This is the slow pathway conduction. The failure of fast pathway conduction in the superior nodal domain permits retrograde invasion of the slow pathway wavefront, forming a reentry, but normally not AV nodal reentrant tachycardia. The described dual pathway electrophysiology is a normal inherent property of AV node conduction. The potential electrophysiologic basis for a jump in the AV conduction curve in AV nodal reentrant tachycardia is also discussed. The next paper is also a topics in review. The title is Ischemia-Induced Repolarization Dispersion Changes and Ventricular Arrhythmia, Validation of Frank Vector Cardiography Parameters, a review by Lennart Bergfeldt and colleagues. The abstract reads as follows. Changes in dispersion of ventricular repolarization is a salient electrophysiologic feature of acute myocardial ischemia and is linked to life-threatening arrhythmias. In 9 studies, the authors applied Frank vector cardiography not only for non-invasive monitoring of cardiac electrophysiology during acute ischemia induced during percutaneous coronary interventions, during clinical myocardial infarction, and in an occlusion reperfusion pig model, but also for prognostic purposes after coronary events. Myocardial ischemia was in humans and pigs associated with significant changes in the ST segment, amplitude and area and ventricular gradient, and T-vector loop morphology. In the pig model, a link between dispersion changes and the occurrence and suppression by spinal cord stimulation of ventricular arrhythmias was found. Prognostically, after recent acute coronary events, the spatial peak and mean QRST angles were superior. In summary, vector cardiography-based parameters were validated as reflecting changes in repolarization dispersion during myocardial ischemia in humans and in pigs linked to the occurrence and suppression of ventricular arrhythmias. The next paper is also a review topic paper. The title is Exploring Serum and Glucocorticoid-Regulated Kinase 1, a Promising Target for COVID-19 and Atrial Fibrillation Treatment by Jeanne E. Fatima and colleagues. The abstract is a summary of this paper, which states serum and glucocorticoid-regulated kinase 1, or SGK1, is a serine threonine kinase that is involved in various cellular pathways such as ion transport, cell survival, proliferation, and immune responses. Dysregulation of this enzyme is increasingly being associated with the progression of 2 predominant types of diseases, namely viral infections such as COVID-19 and cardiovascular disorders such as atrial fibrillation, positioning it as a potential therapeutic target. With regard to coronavirus 2019, SGK1 detrimentally affects inflammatory pathways and modulates the cytokine storm, leading to lung tissue damage. Considering this dysregulation, researchers are exploring SGK1 inhibition as a potential strategy for mitigating severe COVID-19 outcomes. SGK1 also regulates pumps and ion channels, significantly affecting cardiac performance in AF. This protein is responsible for promoting fibrosis and inflammation in the cardiac tissue, making it a potential target for reducing atrial fibrillation. SGK1 inhibition offers a new avenue for therapeutic targets against both COVID-19 and atrial fibrillation. This review is aimed at providing a comprehensive overview of SGK1 dysregulation in both diseases, underscoring the urgent need for more preclinical and clinical trials to evaluate effective SGK1 inhibitors for patients with coexisting COVID-19 and atrial fibrillation. The next paper is a brief report, and the title is Retrograde Aortic Access for Ventricular Arrhythmia Ablation, a Novel Plug and Suture Strategy for Vascular Closure. This is by Dr. Rebecca Arnett and colleagues. The key findings of this brief report include 1. Vascular access complications are frequently observed after catheter ablation of ventricular arrhythmias. Achieving hemostasis may be challenging after large bore vascular access for retrograde aortic access. 2. A novel technique combining a plug-based with a suture-based vascular closure device has been described outside of the catheter ablation population. 3rd, in this study, the combination of plug and suture-based vascular closure devices was feasible and appeared safe to achieve hemostasis in patients undergoing catheter ablation of ventricular arrhythmias using the retrograde aortic access. And finally, further studies assessing a larger patient population and cost effectiveness are warranted. The next and last paper is a Fellows Corner paper, and the title is Pulsed Field Ablation for Paroxysmal Atrial Fibrillation in a Dextrocardia Case, a First-in-Human Experience by Dr. Tongxi Chen and colleagues. This is a case presentation, and the key findings are: 1. Pulsed field ablation was successfully performed for the first time as an efficient and safe treatment of atrial fibrillation with dextrocardia and situs inversus. 2. Consistent views obtained from three-dimensional electroanatomic mapping and intracardiac echocardiography were significant for transseptal puncture and ablation, enhancing the ease and safety of the procedure. And 3. The hockey stick maneuver can be used for right inferior pulmonary vein isolation in cases of low orientation of the right inferior pulmonary vein ostia and less space between the transseptal sheath and the right inferior pulmonary vein ostia. I hope you will take the time to read this interesting paper. And this completes the podcast for the May 2025 Heart Rhythm O2 issue. I'll be talking to you again next month, and thank you for listening.